Thank you and welcome to the 488th meeting of the Economic Club. I'm Marie-Josée Kravis. I'm chair of the Economic Club and a senior fellow at the Hudson Institute. In its 111 years of history, the Economic Club has hosted more than 1,000 speakers from business, academia, government, and has really become the leading nonpartisan platform for conversations and discussions of economic and political issues. I want to especially recognize today our now 270 members of the Centennial Society, some of whom are in the audience, and I want to thank you for your steadfast support of the Centennial Fund, which assures the financial backbone that ensures that the financial backbone of the club remains strong. I also want to welcome our 2008 fellows and remind everyone that applications can be made for the 2019 Economic Club fellows, so that if you have any young leaders that you'd like to recommend to participate in this program, please go on our website and recommend some leaders in which you believe. It's really a pleasure today to welcome Ian Reid, the chairman of the board and chief executive officer of Pfizer. As you know, the club has made a real effort to broaden its program and to include new topics such as technology, healthcare, and of course today the topic that we discuss includes both the biomedical sciences, technology, and of course healthcare. And Ian will discuss the pharmaceutical industry, but also issues relating to the future of healthcare in this country. Ian Reid has had a vast experience with Pfizer. He began in 1978 as an operational auditor. He worked in Latin America, holding positions including Chief Financial Officer, Pfizer Mexico, and Country Manager, Brazil. He became president of Pfizer International Pharmaceutical Groups with responsibility in Latin America and Canada, and then added to that the executive vice president of Europe, and he was named then corporate vice president in 2001, assuming responsibility for Canada in addition to Europe, and later became accountable for operations in both Africa and the Middle East region and Latin America. So he's had a very broad experience in many different areas of responsibility at Pfizer, but also on the international, in the international scale. Ian's a director of Kimberly-Clark. He also serves on the boards of Pharma, on the International Federation of Pharmaceutical Manufacturers and Associations, and the Partnership of New York City. He received his BSc in Chemical Engineering from London University Imperial College and earned his Chartered Accountant certificate from the Institute of Chartered Accountants of England and Wales. Ian will make some brief remarks and then we will continue with the conversation. And we have as our interviewer today the club vice president and co-founder of both North Island and Silver Lake, Glenn Hutchins. So I also want to thank Glenn for leading this conversation. And as a reminder, the conversation is on the record. We do have media in the room. So I'll first invite Ian to come to the podium, and then Glenn will join us for the follow-up questions and conversation. So Ian Reid, to you, and again, thank you for being with us.
Well, thank you, Marie, for your kind introduction, and I want to give thanks to the Economic Club of New York for this opportunity. I'm delighted to be here. You know, as Marie said, 40 years in business, going on 41, and I have developed several strongly held beliefs. Today, I want to talk about 4 of them. One is, I believe that the right incentives are the most effective way to drive the right behaviors. I believe that All regulation has a cost, vastly underestimated, and regulation should provide the guide rails for incentives. They should not replace incentives to ensure the right behaviors. Patients deserve affordable access to medicines. And good insurance, increased accountability, and rewarding well care rather than sick care is the way to fix our healthcare system in the United States. So let me start with the incentives. Now, market-based incentives drive increased investment. They encourage entrepreneurship and scientific risk-taking. They create jobs and economic growth, and in healthcare, they lead to improved patient outcomes. Thanks in large part to the power of such incentives in the US, as distinct from the rest of the world, the US has led the way in terms of global science and technology. This enabled the biopharmaceutical industry to be consistently strong and contribute to the US economy. It also allows a huge infrastructure below that of small biotech companies, entrepreneurs, venture capitalists, joint ventures, universities to exist to create a huge ecosystem which is powering the innovation in the United States. According to a study commissioned by the Pharmaceutical Research and Manufacturers of America, U.S. biopharmaceuticals industry overall impact on the U.S. economy was $1.3 trillion in 2015, representing 4% of U.S. output. Unfortunately, we have seen our science and technology leadership begin to erode, specifically when you look at what's happening in China, where they're producing vast numbers of life science graduates, providing huge incentives for scientists to move back to China, and they are beginning to challenge the United States in terms of patents issued. And I believe this is happening here because of, number one, our regulatory environment, which has become very, very difficult, and well-intended policies that have stunted rather than enabled growth. Such things as legislation around safe harbor, Medicaid best price, the spread from concessionary pricing given by the industry to the VA and to Medicaid into commercial businesses, into states arguing that they should get the same price as VA in California, which was clearly a concession by the industry to allow cheaper access for our armed forces. Policies that favor hospital treatment rather than using the most effective treatment, which is early use of medicines. So I think this is why it's really critical that we address this and we advocate for pro-growth, pro-innovation incentives, as well as appropriate regulations to benefit both businesses and society at large. Examples are increased funding for basic research. The US is slipping behind on that, the amount of money we spend on basic research. Addressing the unfair free riding by foreign nations on the IP generated in the United States. Increased funding for STEM-based education and training, and more importantly, or most importantly, restructuring incentives to reward well care rather than sick care. I'll talk a little bit more about that later on. Such policies, such incentives, I believe, will allow the US multinationals in pharmaceuticals to continue to invest in innovation in the belief that they will be rewarded, and it will ensure that foreign countries pay their fair cost of innovation, and it will also ensure that we have the skilled workforce we need to continue to win in the United States. It also motivates the rest of the system to achieve a goal of health care, not sick care. Medicines are the most effective way of controlling healthcare costs, medication and personal behaviors. It's too late to shut the gate once somebody is a type 2 diabetic and it's gone so far down the road that the only way is to have intensive health care and hospitalizations. That's why the costs are so huge. Let's talk about regulation. Now, regulation, it has a cost. And I think our society today in the United States has lost its way with regulation. We see regulation as the way of ensuring perfection. And we see more and more regulation piled on to businesses, and we don't really address the cost. Take biopharmaceuticals, for instance. You know, we're acutely aware that patients take our medicines because they trust in our clinical trial data, and they trust that our medicines will do what they say they will do. We don't actually sell pills. We sell information, credibility. We sell the fact that people believe we've done the trials properly and our medicines will do what they're expected to do. However, there needs to be a balance between ensuring patient safety and creating criteria and process and so onerous that they significantly delay the delivery of new life-saving medicines. And this has become a problem in the United States. If you go back, it takes us 10 to 15 years to bring a product to market. I would say that's clear evidence the balance is way out of whack. The cost of people waiting is not weighed into the cost of regulations. In December 2004, for example, Pfizer was required to submit about 198,000 pages, 7 gigabits of documentation to the FDA as part of an approval process for Tigersil, an antibiotic, an important product, a major submission. In June 2017, we needed to submit 9 million pages, or 251 gigabytes of documentation, for a labeling change on an already marketed product called Celebrex. And this data came after the product had lost its exclusivity. That's a 45-fold increase. And this is repeated across many products. If you take a slide I have here, which I can't show you, but you can see from Tigersil of 7 gigabytes in 4. In 5, it became 21 gigabytes. In 11 for Xeljanz, it became 69 gigabytes. In September of 12, it became 100 gigabytes. And finally, Celebrex with 251 gigabytes. This increase, this striving for perfection, this striving for absolute safety has a cost. I don't think this data, does this additional documentation make products safer? I think it's unclear. Has it created greater good? I think that's unclear as well. I think we do not appreciate the significant added cost and time to market of innovations and lives that could have been saved if more risk was allowed. The frustrating irony is the pace of scientific advancement and our increased ability to demonstrate safety and efficacy are improving every day. Our ability to manage data, our ability to see real-world data, our ability to interrogate data post-launch is far more advanced. So our regulatory system is totally antiquated for what we need to do to bring drugs quickly to the market. I am encouraged by what Commissioner Gottlieb is doing. It's a beginning, it's tentative, it requires a lot more support from Congress to enable us to bring drugs faster to patients. The third topic, affordable access. I want to discuss this in the current debate regarding the affordability of medicines. Most people would agree that medicines are essential to modern life, and they have greatly contributed to overall welfare of society. But bringing innovative medicines to market is a high-risk, high-capital endeavor. To discover and develop a new drug, the biopharmaceutical industry spends on average 6 times more on R&D as a percentage of sales compared with other major businesses in the US. As a result, medicines are going to be expensive. Individuals cannot afford modern medicines out of pocket. But the benefits to society are huge. It's just how do we distribute those benefits is the issue. So the challenge is balancing affordability for patients with ensuring the industry's ability to appropriately recover its costs and make a return on its investment. I think to have a meaningful dialogue on this issue, we need first to contemplate 3 fundamental questions. Is society paying too much for biopharmaceutical innovation? is the biopharmaceutical industry being overly or unfairly rewarded, which is sort of the other side of the coin, but not exactly. And are patients paying too much for medicine? This is briefly discuss each question. Is society paying too much? Of course, I'm biased, but I do have facts on my side. I would argue it is not. Innovative medicines and vaccines help people live longer, healthier, more productive lives. If we just look at one particular instance, which is statins, I picked that out because we were a developer of an important statin. Healthcare studies have shown that from 1987 to 2008, the use of statins generated nearly $1.3 trillion in economic value for the United States. These are published studies in important journals. $950 billion, 3/4 of that value was retained by society. Only 1/4 of the value accrued to the industry through sales. So the industry retained 25% of the value, society retained 75%. And that is before you even take into account that statins are now generic. Their prices dropped 90%. They're now available to society for a lot lower price but the same great value. Now this story it's been repeated in cancer treatments, precision cancer treatments, rheumatoid arthritis, hypertension, diabetes, GERD. Every area you look at, there's been a huge societal benefit from our industry. For these benefits, the US spends 1.8% of our GDP on prescription drugs. That percentage is comparable to the other 23 OECD countries, slightly higher as a percentage of GDP, probably 0.4 higher. But significantly less than the 11% the US spends on hospitals and outpatient care. So hospitals, outpatient, 12%, 11% of GDP, drugs, 1.8% of GDP. That's the difference we're talking about. The other question is the pharmaceutical industry being overly or unfairly rewarded? Clearly, I see no evidence of that. There'll be no surprise to you that I'm going to say that. Now, individual drugs are hugely profitable. 12 years, capital risked, 10% chance of success, it better be. An individual drug better be hugely profitable to pay for the process that produces those drugs and has 90% failure along the way. But if you don't believe me, look at the marketplace. There are 25 major industrial sectors in the Bloomberg Index. We rank 20th in terms of price-to-earnings ratio as an industry. We rank 10th in terms of return on equity and 13th in terms of return on capital and 9th in terms of assets. I see no evidence of an overall profitable rent-seeking pharmaceutical industry. Are patients paying too much? Yes. Unfortunately, in many cases they are. Patient cost sharing has grown dramatically since the implementation of the Affordable Care Act. Patients are paying far more out-of-pocket for medicines than they do for all other health care. Patients can on average pay out of pocket 13% for their prescription drugs. They pay 3% for hospital care out of pocket. This seems the wrong way around. We want to keep people out of hospitals. We want to make them well. We want to give them help to change their behaviors, and we want to give them access to medicines and keep them out of hospitals, but they're paying less to go to hospital than they are for their drugs. So how do we fix this? I think there are two issues. One, how do we immediately relieve some of the burden of people at the point of access, the people who are paying for their drugs in pharmacies? The industry has take 100 for its selling price. The industry gets 50 cents out of that 100. The other 50 stays with the distribution channels and insurance companies. Now, true, a lot of that, some of that goes to lowering premiums for everybody. So the people who need the medicine most, who need the insurance, are paying more than healthy people. So there's no sharing of risk. It's all being dumped on the poorest and the most needy of our society. That's one thing we have to change. And secondly, we need a better insurance system. We need a better way of ensuring people have access to medical insurance. We need to change this whole emphasis, which has become balkanized between the pharmaceuticals, the PBMs, the hospitals, the physicians. We need to look at a way of ensuring that there's a clear incentive and not regulation to fix this. You may be able to write 2,000 pages of Affordable Care Act. It's not going to work. You have to change the incentives. We need to move the incentives to the providers, to the hospitals. We need to pay the hospitals, who are the people who should be taking the risk, who hold the patients, who have the knowledge. We need to pay them for well care, pay them for reduction in cholesterol, reduction in diabetes, reduction in hospitalizations, reduction in infections in the hospitals. We need to move the incentives there, and I believe that will create a sustainable healthcare system that is efficient. So we need a drastic change in incentives where insurance companies are not perversely incentivated to avoid insuring people who are ill, who don't take all drugs in one category and put them all at a high copay and a high co-insurance because they don't want those patients. You understand, if you're an insurance company, you want to avoid people who are sick or likely to be sick. So you don't want to cover products that stop people smoking. You don't want smokers in your pool. You don't want people at high risk in your pool, so you do everything you can to avoid them. This is not what we want from good insurance. So I think by shifting that risk to the providers and giving them a fair return on that risk, we can clear up a lot of these misaligned incentives in the system. So this is this balance between incentives and regulation. 2,000 pages of regulation, 3,000 pages, or just clear incentives that would allow the system to work efficiently. So in closing, over time, thanks to these market-based incentives that have worked or were working in the United States, we have a vibrant industry. Huge gain for patients, huge social gain, huge GDP, very positive. We have turned fatal illnesses like HIV into chronic conditions, made huge advances on cancer, cured hepatitis C. Rheumatoid arthritis has become a disease you can live with. A lot of diseases of the immune system we're now beginning to tackle. So we've helped prevent widespread child illnesses, rotavirus, chickenpox, pneumococcal disease. We've reduced mortality rates for cardiovascular and diabetes. We have revolutionized the care for some patients with personalized therapies in cancer. This can continue. If we get the incentives right, the next decade of medical discovery will prove to be even more amazing as we go to targeted silver bullet therapies for cancer and other immune diseases. I believe we will get this right, but right now it's a serious societal debate about where do we go on how we pay for innovation in pharmaceuticals. It's important that the United States continues to lead in science and technology and medicine, and we need to get this discussion up front and stop the demagogue natural reaction to always point to the pharmaceutical industry and not really address the serious issues, which is a matter of wrong incentives. Thank you very much. With that, I think Glenn's coming up.
My name's Glenn Hutchins. I have the privilege of calling myself a friend of Ian's. So Ian, thank you very much. That was really interesting. Well done. So let's start with the whole issue of your opening comments, the whole set of issues you raised.
Yeah.
You raised so many, we don't have a huge amount of time to get into those, but expand a little bit on your statement about advocating for pro-growth, pro-innovation policies benefiting both business and society. Can you give us some concrete examples of both what the problem is and how that might work better?
Well, in the regulatory sphere with the FDA, there is this total focus on safety, but a mismatch between benefit and risk. The FDA is a great institution. I'm not criticizing the people that go there. They have a mission, but they don't see it in terms of economics. So every post-marketing study we do, every trial we do to satisfy their everlasting search for perfect safety takes away money from innovation. There's no societal way of calculating that. You have an institution which is protected, whose only remit really is not to be caught, not to approve a drug that turns out, unfortunately, to be less safe than they thought. And that's what their remit is, and they do it. That leads to huge costs.
So what would you do differently? What would you have them do differently?
Well, I think you need to try and have a more explicit cost benefit. I think you need to have well, we're going to approve this drug, but we want the company to do a post-marketing to satisfy this point on safety. Okay. What's the risk? What's the cost? Is it favorable? I think society needs to have an adult conversation about what risk we're willing to take in approval of medicines. I would give you an example. Vaccines are very difficult to approve because you have a low incidence, high efficacy, low incidence, so you need huge clinical trials. Prevnar adult, we had to run 85,000 patients through a trial. So, perhaps you could look at vaccines and say, well, if we've got safety data and we have in vitro indication of efficacy, why don't we write a registry? Why don't we let the vaccine go into the population, monitor its safety, and real time see if it's preventing? So therefore, I don't have to have 50,000 people in a trial to show that 10% are protected. Because all the time that's being done, patients are dying because the vaccine isn't there. And no one adds up those costs.
I was going to say, how do you capture those costs effectively?
Well, you need to calculate what is the expected efficacy of the product. What is the value of that versus waiting 5 or 10 years more for an incremental data point.
So what you're saying is you can actually prove what you can in many of the cases of cost-benefit analysis, the counterfactual, because you can see the patients that are suffering as a consequence of not having the drug?
That's right. You go into what we would call an enriched population. You go into people who actually have the condition,
right?
And you treat them, and therefore it's vaccines is a particular example. But in general, look, it takes us, I don't think it's an easy answer. I'm not here to criticize the FDA. I think the FDA reflects what society has asked it to do.
I think you've had a very measured response to this. You're not vilifying anybody. You're just saying we can do it better.
Right. So, for instance, we apply for a IND for a new medication. We have to send it down to the FDA with certain data. They look at it. They get back to us. Of course, they want to change. That was why they're there. So they send it back to us. Another 3-4 months goes by. We look at their changes. We resubmit. Another 3 to 4 months go by, and then we get the approval to start. And this happens in every stage of research. Every stage, there is this delay, and delay costs lives.
So that sounds like there's an administrative solution there, which is to sort of engineer a process better at the FDA.
Well, the FDA continually tries to do that. Every year we have every 5 years, isn't it? We have a discussion with the FDA on the funding that we provide to them for the work they do on approving our drugs. And we continue to try and incite them or incentivate them to have better project management, to have consistency between their different divisions. The best divisions are in oncology, because it's the fastest, because the need is greatest, and they move fast. Our divisions move very slowly. They have different opinions of what is needed by society. So you need to have more transparency in what the FDA does, or you need to find better incentives to ensure that it can be done faster with appropriate risks.
So the reason why I asked that particular question is I find myself wondering as you talk about this, whether there are things you want an FDA administrator or a motivated administration could do as opposed to what requires fundamental legislation. How big a task is this, and are there solutions along the way?
I think it's nibbling around the edges without fundamental reform.
Fundamental reform means legislation?
Legislation.
Gotcha, okay. And what would be, in your ideal case, what would be in that legislation?
Well, you'd need to modernize the act that says you need 2 prospective randomized trials. which was 1956 standard of efficacy. You'd have to look at, do we allow registries? Do we allow having cleared a certain bar of efficacy in vitro and safety? Do we allow registration trials and approval post-launch? I mean, these are the sort of things that would speed up medication. Now, I'm not saying it's easy. I still think you clearly, society has a role. Society wants to feel that their medicines are going to be safe. But I would argue that Pfizer, more than anybody else, is incentivized to make sure medicines are safe. We're a $260 billion cap company. We sell our medicines on our reputation. We have every incentive to make sure our medicines are safe.
So you're looking at the politics. Obviously, you've had to become, these days, CEOs have to become experts in politics. What's stopping it? I mean, this is not a comment on the politics of the moment. It's a broad comment on the politics.
What's stopping it is this fundamental divide in our society where certain parts of society want to be protected by a state, by government organizations, and there's this huge distrust of being in commerce.
And a huge risk aversion.
Right. No one wants to take accountability. So it's our society drifting towards this, no accountability, let somebody else take the risk. Because they can't measure the risk, they can't measure the cost of not having those medicines.
Interesting.
Probably even see it in self-driving cars.
Right.
Right.
I found myself thinking, as you talk about this, whether there's a broad-based approach to regulation that enshrines a risk-reward or cost-benefit kind of analysis that's broadly applicable,
yes,
as opposed to just thinking about health. And that's what
I think you do. I think society needs to, and it comes into healthcare as well. When you say, what can we do? The most powerful way of lowering healthcare costs is having individuals look after their health, being conscious of their decisions they make. So Pfizer, as a large employer, tries to give incentives to our colleagues to not smoke, to exercise, to reduce their weight, to seek for help if they have mental conditions.
No incentives for reducing your handicap?
None, unfortunately.
No.
That's considered bad news as far as the U.S. But so we try and do that, but we're very limited. The present regulation, not by Congress, but by a body who's set there to look at to issue the regulations on what Congress has passed, says that if you offer more than 15% of the value of the healthcare to your colleagues, it's not permissible. You can't give them healthcare incentives greater than 15% because then they consider it coercion. So I would like to be able to say to my colleagues, the market-based cost of health insurance for you is pick a number, $20,000 a year. But if you'll do this, this, and this, and have an outside party validate it, I'll cut it to $10,000.
And you couldn't do that today?
I can't do it. It's illegal.
So this is the issue you described earlier as incentives. You can change the incentives in the system, and that translates back through.
Correct. I can't incentivize colleagues enough to change their fundamental lifestyles with $1,500
right,
or $400 off their premiums.
Well, it might be. Interesting.
Right.
So that gets us to the next topic we want to talk about, which is you describe going from a healthcare system where it's volume-based reimbursement to one which is value-based reimbursement.
Right.
So talk a little bit first before we get into that question. What do you mean by how it would work, and what do you mean by, and how do you measure kind of value and value-based?
Well, today you're paid in hospitals, you're paid by everything they do. You're paid every machine they use.
This is volume-based.
This is volume-based. They're paid on a code that's issued by the government, huge regulation, it's audited, it's changed, thousands of people trying to administrate this, trying to get the right coding and what the doctors do, what machines they use, and then you get paid by it. That's irrelevant. Who cares? Go in and say to a hospital system, because now they are integrating, they're becoming larger, they're owning populations. Mm-hmm. There's 95% of the people stay in their own, that captured pool of these big integrated hospitals. So assess the risk of their population and give them a per capita amount. I don't care what you do. Here's the per capita amount. Next year it's going to be lower. Fix the healthcare of your population. I don't care what machines you use, how many MRIs you've got, but will have quality indexes. And if you can get healthcare down, if you can get improving healthcare, which is less people going to hospital, less cost, less sickness, you're going to make more profit. Why do we need all these regulations?
So wasn't that, are you talking about what, if I had it right, the Affordable Care Act, otherwise known as Obamacare, called Accountable Care Organizations, ACOs? How is that different than that concept?
Well, I don't think the ACOs have that degree of freedom.
That's what I was wondering. So
And
we get back to the restrictions that are placed,
and they're competing against massive hospitals and insurers that don't want to play that game.
But don't many of the hospitals have their own ACOs?
They're starting to, but they have to interact with Medicare, Medicaid, Medicare Advantage. They're not working in a system that totally liberates them to be able to move towards that. Now, society may be moving there slowly. I think it's too slow. I think there are too many disincentives. An insurance company doesn't hold you for long. Maybe holds you for 5 years. They have really no incentive to pay for products longer term. And it's going to become very acute when we go to gene therapy. Who's going to pay for gene therapy? I'm going to go in and with one injection, I'm going to fix this patient for 15 years. $1 million? I don't know what the price will be. I know what I've spent on investment. I know the value of that medicine to society. That's what should dictate what I get for it. What's the value of the society, not what I spent. But even just on the value, insurance companies will say, well, I'm not going to recuperate that value.
So where is the big impediment in the system? You think through a risk-based, population-based system for the reimbursement for healthcare. You've got the providers of hospitals, you've got the doctors, you have the insurance companies. How do you organize that differently to accomplish that? And where is the opposition to that change?
Well, the opposition comes from everybody who's got an entrenched interest, including the pharmaceutical industry.
Right.
Right?
We're going to get to next.
Everybody's got an entrenched interest. Everybody tries to use the regulations to protect their part of the system, and this is what makes it become so difficult. So you can, my view is you cut through all that by the right incentives. So I would just say, my point of view is that you look at populations and you look at the providers and you say, look, this is the health statistics in your area. This is the costs. We're going to pay you a fixed amount per patient based on insurance company calculations. We get paid a fee for that. Right. They're not being paid on taking risk. They're not taking the risk. It's the hospitals that will take the risk. And we get out of the business of micromanaging healthcare, and we pay the hospitals, and it's their problem because they have knowledge. They understand the whole healthcare continuum. It's up to them to react to those incentives to improve healthcare. Now, of course, you need guardrails. You need to protect patients from hospital systems that may be too rapacious. I believe there is a place for guardrails in that. But in general, you don't need 4,000 pages of regulations.
So as you were speaking today, the headline came across that the Justice Department had approved the CVS Aetna deal. And are there changes of that sort, structural changes that are going on in the industry that move in this direction, that can facilitate this from happening?
I haven't studied it in detail. It's what they call a vertical integration.
Right.
I am extremely suspicious of any system that leads to less choice. If it does. I don't know if it does, but if it leads to less choice, I think it leads to worse outcomes for patients. And that's fundamentally what will happen with our industry if society is not willing to pay for the innovation, if we can't collect from foreign countries like Germany, like the UK, like most of Europe, if we can't collect the fair value of our innovation from those parts of society, then the industry will consolidate and there'll be less choice. You won't have the fifth statin being the best statin ever. You'll have the first statin, which was not a great product, and you'll pay for the nose for it.
So you see the primary driver for this being pressure. That takes us right to our next topic, which will be pricing. I'm sure you're not surprised we're going to talk about pricing today. But pressure to get costs down and one of the costs that will come down is sort of the cost of pharma, but represented by switch from branded to generic in the system. and that means less choice for consumers? Is that how to think that value chain gets down to companies like Pfizer?
Yeah, I mean, our point of view is we 90% of the pharmaceutical volume is already generic. That's a huge number. That shows us that.
Is that by dollar?
It's by units.
Units.
By units. Clearly, for dollar, it's different because of the price equation.
That's what I think.
So, but you've got to look at our situation. We don't have a business 10 years out if we don't invent new drugs.
Sure.
That are proven to deliver more value than the generics. Now, the question is, who judges value? Right? The value, first of all, what's the value to the patient? What's the value to society? What's the productivity of patients? None of this value is calculated. The whole myopic focus is on, well, I've got to spend less on pharmaceuticals. I'm going to spend a lot more on hospitalizations. I'm going to spend a lot more in sick care, but I've saved money on that specific issue. It's very easy to finger point at our industry. Politicians like to do it because you get these situations where a cancer treatment is $10,000 a month, or a rare disease requires, $300,000 a year. Well, these are small populations that have taken huge risk and huge capital to come up with these solutions, and it's a societal question. The society needs to decide, are they going to provide the resources through a pooling of insurance risk or a pooling of incentives at the hospital level or not? And, getting better products for less money, we could do that if we have a faster regulatory system. Every month of delay in our pipeline costs us $300 million. So if we have a lot faster regulatory system, if society is willing to bear more risk, then we could move drugs faster. That will not make them, what will make them cheaper is more competition, more drugs competing for the same patients.
So your view is that's a win-win?
It's a win-win.
Get price out of the system, get competition up as a company.
Yes,
Cost
right.
out of this, cost of delay.
Right.
So let's go from value to price.
Mm-hmm.
This is not an expert audience in the room, so can you frame the price of pharmaceuticals debate, define both sides, and help us understand what's in the debate, what's at debate?
Well, there are two different sort of parts of the argument. The what I would call the tactical part is that we have this convoluted system which grew out of a law case back in the 60s, where we went to a rebate system.
Right.
And this rebate system initially was successful in...
Rebates from whom to whom?
From the pharmaceuticals to the payers. And these rebates were to force down prices by ensuring that pharmaceutical companies were competitive with each other to get greater volume. And that worked for a long time until we got to a situation where we have PBMs were introduced into the system. They're pharmacy benefit managers, who basically part of their remuneration comes from how big the discount is. And so we took focus off the list price and focused it on how big the rebate is. So the PBMs were not really incentivated on list price. They were incentivated on how much of the rebate they could capture, and their contracts are written with the providers as to how much rebate, not net cost, how much
rebate they generate.
They generate.
Right.
So now it becomes a game of, well, okay, increase your price and give me a bigger rebate. Or even worse, you've got a dominant's a bad word. You've got a major product in a category, and it's selling $6 billion a year and giving away $2.5 billion in rebates to the system. It goes through the PBMs, through the insurers. It's intricate in the whole system. And a competitor comes in, better, newer, but doesn't have any rebates. Its rebates you can offer to the system are $100 million.
And why is that? Why can't
Because it doesn't have the volume.
Doesn't have the volume yet.
And so this is a chicken and egg. Now,
Right,
so the only way it can get its volume is if the doctors use it. But the doctors can't use it because it's not on formulary.
Right.
Because the insurance companies, the PBM, say, well, I'm not getting any rebates from this, so I'm not putting it on formulary. So there's this whole system.
It's rebate dollars, not rebate percentages, that drive the system. So new drugs are disadvantaged by
rebate dollars, the volume of rebate dollars.
Right.
So we have this particular situation with our biosimilar, which is, my point of view is when your patent's expired, it's expired. Now I'm going to defend my patent for as long as I can, but when it's expired, it's gone. Biosimilars are the large molecule equivalent of generics. Small molecules. Now, it's a bit more complicated than small molecules. It's a living process. It's not so easy to ensure that the product's the same, but biosimilars are considered equivalent. They haven't given the word substitutable, but they're considered equivalent. They're given the same label. So we have a situation, we've launched a product for rheumatoid arthritis as a biosimilar, and it's 30-40% cheaper than the originator. And but the insurance companies and the hospitals won't use it. Why? Because they've signed contracts that say they can only use the biosimilar if the original has failed. In other words, you can only use an exact copy if the original's failed. Why would you use the exact copy?
And who's that contract with?
Those contracts...
Or with the PBMs?
Those contracts are written with the PBMs and the hospitals and the payers. It's a
huge impediment.
It's a huge impediment to the flow of new innovation. And but to be truthful, the industry has in the past been advantaged by this. I'm not. Everybody's guilty here. What I'm saying is, we need to change that. The time has come to say enough of this, because it was okay when the rebates were 10, 15%, but now they're 50%.
So, but the other side of the pricing debate, so everybody personalizes healthcare. I'm the father of a child with an allergy. We have EpiPens all around our house that we can afford the price, but the price is now 5 times what it was not long ago.
A regulatory failure.
So how that's another part of the pricing issue, isn't it?
EpiPen is a market failure. And
there are other examples of that,
There's lots
too.
of all of these examples you see that come out in the press, and the product's costing $10,000 here and $10 in Europe.
Are these vast pricing?
Are these results of exclusivity given by regulations? So the EpiPen is a great product. It's the active ingredient in the pen has been patent expired for a long time.
So it's one of the few pharmaceuticals you buy that you don't want to use.
Well, most you really don't want to use, but you have to use.
You buy it not to use it.
But anyway, so the point is here. The reason why it was protected was because to be AB rated, i.e. substitutable in our system, it has to be exactly the same as the original. But the device has a patent. So if somebody comes in with a different device, has a different instruction leaflet, it's not AB rated. This is just regulations. This is FDA. This could be fixed like that.
So why isn't it fixed?
People don't want fundamental reform in the healthcare in the regulations. There's a huge industry around maintaining these regulations. All these products that are orphan products that are being used in Europe for nothing. The FDA just has to say, we'll allow importation. I don't like that, because you've got a bad distribution system. They just have to say, we'll give a license in the US based on the data generated in Europe. But they don't. So you've got to generate the data in the US, and then it becomes a huge barrier. So all the FDA has to say is, we'll use European data and we'll authorize the use for these medicines in the US, and all of that would disappear.
So you mentioned importation as an issue. The current administration is focusing on drug prices. There's some notion that they're going to do something about it next year. They're also talking about...
well, they would if they get the incentives right.
Okay, so let's talk about that. And they also are talking about importing cheaper drugs from Canada. So reflect on those dynamics.
Well, there's 2 problems with that. Number one, Canada does not guarantee the quality of drugs that are transshipped through its border. So you're not buying drugs that are available for Canadians. You're buying drugs that have landed in a warehouse, a duty-free warehouse in Canada, and then are reshipped out of Canada to the US.
So they would be manufactured in the same facilities, places like Ireland or other places?
No, they'd be manufactured in China, India, Peru.
So these would come from second and third tier manufacturing sites.
Anywhere. And so you have a whole problem of the safety of the supply chain. And then secondly, from an economics, as we're here in an economic club, you're importing the industrial strategy of the poorest nations. By allowing importation of products that are patent protected in the US, you're saying your industrial policies to set your investment of the lowest level of developing nations. It's absurd.
Interesting.
Right?
So, okay, keep going.
Now, you can import products from Canada. You know, I'm not saying that all of it would be transshipped, but if you try and import products from Canada, what do you think the Canadian government's going to do? It's not going to see all the products sucked out of Canada, and we really can't change our supply, or probably wouldn't be economically prudent for us to change our supply policies. We'll supply Canada for Canadians. Our deal with the Canadian...
We say you, we,
the
Pfizer
industry,
would...
The industry would supply Canada for Canada's use at Canadian prices. That was right. Now the question is, we come to that dilemma. Why is it that Canadians buy cheaper than the United States?
Right.
Well, Canadians get their medications 3 years later than the US. They don't have investment, they don't have an economy, they don't have the GDP contribution, and they're monopsony purchases. You only have one buyer.
Monopsony, that's a good word for the economics club. Well done.
Yeah, monopsony purchaser. So,
Joe, do you know what monopsony means, Barella? No? Sorry, don't worry.
Monopsony purchases. So monopoly is the other side of that.
Yeah, monopsony is a monopolized sell.
Yeah, monopsony. So
buyer.
Here's the situation. We go to, we Pfizer, the industry goes to a Germany or a UK, or look at Denmark, look at Canada, look at the Netherlands, any of these developed countries that are extremely wealthy, but they have no pharmaceutical industry. They have no interest in paying for pharmaceuticals. There's no industry to support. They just want a free ride on the development in the United States. And there's only one purchaser in that country. So you go to them and they say, well, you know, I know you're getting $100 in the US, we'll offer you 10. And so 3 years later, when they haven't got the product, they eventually offer us 40. If we're lucky. And I may say, no, I'm not selling it for 40 because it's worth 100.
Right.
They say, well, you may not, but Novartis or GSK or your competitors, I'm just picking, I don't mean to name them, I'm just picking competitors.
Right, sure.
Competitors have a look-alike product. It's 3 years later, but it looks much like yours. And they are going to give us a deal. So either accept the 40 or have nothing. Now, if I accept nothing, I have to increase my prices in the United States to pay for the innovation. So we're forced to acquiesce to what we consider prices below the value of the medication. They are confiscating our intellectual property. Is that clear?
I think so.
I explained it another way to somebody.
Yeah, no, I understand.
Yeah.
So we're basically out of time here, and there's much more we could talk about. But you've just announced recently your retirement from Pfizer as CEO, but you spent your entire career there, right?
I did, my entire industrial career.
As CEO, I've got some numbers here. Total shareholder return of 250%, outdoing the S&P 500 by 180 percentage points, 100 basis points during that time period, or percentage points. 120 billion of direct capital return to shareholders, 70% increase in dividends. But also, since 2010, you've donated more than 580 million doses of Zithromax to treat infectious blindness in the world. So as you look back on your career and think forward, what advice would you give the CEO of the future, not just CEO of Pfizer, I think he might be here, but CEOs operating in this marketplace today? What have you learned, and what would you share with us?
You know, I believe that you need to do, I'm talking about running a company, the first thing you need to do is get the culture right. If you get the culture right, you have everybody in the company working to the same purpose, the same objectives. Culture is so underestimated. It's so funny, when I talk to analysts in the US, they don't want to even hear about it. But if I go abroad, all they want to talk about is the culture.
Interesting.
It's strange. But the culture fundamentally defines how you harness all the energy in the company. And after culture, you know, it's integrity. It's integrity, which is part of culture. It's focus on patients. And we really have this expression of Pfizer: patients are waiting. So there's a sense of urgency in everything we do, in the laboratories, in our trials, the way we spend our money. And so I'm proudest of the culture and what we do per se, which is focused on healthcare.
So for the millennials, there's a lot of discussion now around young business people about trying to find ways in all businesses to do both well and good. And Pfizer has been uniquely situated to do that. What kind of advice would you give to young people who are thinking about that kind of ambition for their business careers?
Well, I would postulate that in most businesses, focus on doing well, and automatically you're doing good. I don't see that as a division. I think if you have a purpose in your company and your purpose is aligned with society's purpose, which most purpose statements are,
right,
because you're there to meet patients or you're there to meet consumers' needs, do that really well and you'll do good. So we had a discussion, I'm going to take a bit more time. You know, we're seeing a lot more involvement of CEOs in social issues.
Right.
So I decided, you know, to call an ethicist, and my leadership team had a day off, and we went and talked to this guy about what should our response be to these social issues as a company. And we debated and we talked about it, and we came up with like 3 or 4 principles. The first one is, when there is a social issue, we look at it and we say, does it interfere with our purpose? i.e., inability for talented individuals to get visas to come to the United States. Yeah, it interferes with our purpose because we need the brightest and the best to do the research. So we will be vocal on that.
Right.
If it doesn't pass the purpose test, then we say, okay, does it impede our ability to do our business in the sense of, can we still hire the best and the brightest? Will our population, will our potential actual population of colleagues or future colleagues not want to come to Pfizer because we haven't taken a stand on this issue? Then we decide whether to take a stand. And those are the real 2 biggest areas we look at. And if they don't meet those 2, we don't say anything. We don't think it's part of our purpose or part of the remit of, you know, there's no CEO-driven social agenda. It's driven by that logical thought process.
Very interesting. Ian, congratulations on all you've accomplished, and thank you for coming today.
Thank you very much. Thank you for inviting me. Thank you.
So thank you both, Ian and Glenn. Ian, you've always been known for your candor, but thank you today for sharing some very concrete recommendations, suggestions, action points, and for, of course, informing us in more depth about the issues facing the pharma industry. I'll just remind people attending here today that as much as we point the finger at the pharma industry for healthcare costs in this country, the cost of pharmaceuticals represent about 12% of spending on healthcare. In the case of cancer, it's about 14%. So as much as it is an important issue, and Ian has given us a roadmap of addressing some of these issues, we still have to continue this discussion about healthcare costs in this country, and we intend to do so at the club. We will change gears, though, tomorrow. We will have Reid Hoffman, who's the founder of LinkedIn and a very active VC investor in Palo Alto and throughout the country. And he will be in conversation with Eric Schmidt, the former executive chairman of Google and Alphabet, and now still a member of the board of Alphabet. So that should be an interesting discussion at the Hilton. And then next week, Barry Diller will be in conversation with Andrew Ross Sorkin. We'll have Randall Quarles of the Federal Reserve. And then Friday, Mark Carney, the governor of the Bank of England. So I think it's a very exciting week ahead, and I hope you'll join us. Thank you and enjoy lunch.